This is chapter 13 from the 11th edition of the textbook of radiographic positioning and related anatomy. This is the section of the lecture that would include a barium enema single contrast study. We had discussed last time in the small intestine lecture, chapter 13 does talk about the small and the large intestine and the imaging that takes place with that. We had referenced at that point in time that there are some differences between the small and the large intestine. Mainly, the small intestine has a smaller internal diameter compared to the large intestine. The small intestine is more centrally located in the abdomen versus the large intestine tends to line the periphery or the outside of the abdomen. The large intestine has pouches or haustra that are formed by the Taenia coli, and the small intestine does not. Another difference would be that the small intestine, there is far more, almost 3 times as much small intestine as compared to large intestine. This is a barium enema or a BE. This is one image. This is actually from a double contrast study, which we are not going to discuss in this lecture, but there will be a subsequent lecture. So barium enemas, the purpose is to radiographically examine the large intestine. And like I said, this double contrast study, typically what that means is that there is one positive contrast media. In this case, it is the barium sulfate, and there is a negative contrast media, and this would be the air that was pumped in. So you can see that you tend to use the barium to outline the wall of the intestine. You can see the haustra all outlined in here, and then the positive contrast media fills the other sections, and the radiologist can move that around depending on when it's going in. And then with the compression paddle, you can see here the retention tip. This is the enema tip right here, and this is the retention balloon inflated. When they talk about the large intestine versus the colon, a lot of times you will hear texts use this interchangeably, but that is not really the case. They are not to be used interchangeably because they reference different anatomy. So when we look at the colon, when they specifically discuss the colon is actually only 4 sections of the large intestine, and it includes the cecum and the rectum. So the colon includes ascending colon, transverse colon, descending colon, and the sigmoid colon. It also includes the flexures between the transverse and descending, which is your left splenic flexure, and the flexure between the transverse colon and the ascending colon, which is your right hepatic flexure. So those 4 sections plus these 2 flexures is the colon. The large intestine, that goes from the cecum, which is the blind pouch in the beginning of the large intestine. It includes from the cecum all the way through ascending right flexure, transverse colon, left splenic flexure, descending colon, sigmoid colon, and the rectum. So the large intestine includes the cecum and the rectum along with the entire colon. When we look at the cecum and the terminal ileum, this is actually on page 502. This is figure 13.9. This is the terminal portion of the small intestine, the ileum. Notice the spelling. And then when food or chyme passes from the small to the large intestine, it passes through the ileocecal valve. And then it enters the first part of the large intestine, which is your cecum, which is this blind pouch. Okay. If the patient has it, then off of the cecum, they would have their vermiform appendix. Vermiform means worm-like. And typically the appendix is usually anywhere from about a half an inch to probably about 8 or 9 inches long. So this worm-like appendix typically, they talk about the fact that it has a blind ending, and sometimes what happens is you get infectious agents that enter this, and then it becomes inflamed, and that leads to appendicitis, which means that the patient might be required to have an appendectomy, which is where they remove the appendix. And we'll talk about that a little later. Now the ultrasound and CT tend to be the modality of choice if the patient is suspected to have appendicitis. So as we said, a small bowel study on that lecture, we talked about a small bowel is deemed complete when barium passes through the ileocecal valve, and then they take a spot image of that valve for proof. A barium enema, on the other hand, is deemed complete when barium either fills the large intestine and refluxes through the ileocecal valve, so you basically get backwards flow into the ileum, or when barium fills the appendix. Either of those cases would deem a barium enema complete. If barium fills the appendix, or if barium refluxes through the ileocecal valve, then the study would be deemed complete. This picture of a barium enema, it appears like it could be a double contrast BE, but it also might just be the fact that the barium hasn't made its way all the way around, but they're doing an overhead. I'm not really sure why. You can see the enema tip right here along with the inflated retention tip, a retention balloon. So that is still in the patient when they took this. You can see the barium filling the rectum, the sigmoid colon, which typically has an S shape. This would be the descending colon, left splenic flexure, transverse colon. Remember, this is the most flexible portion of the large intestine. Sometimes with the weight of the barium, it can actually have it droop down into the pelvis and then come back up to the right hepatic flexure. And then it would come down the ascending colon. Because we put this in retrograde, it doesn't flow normally. Normally, food and digested material would come out of the small intestine and go in this direction, down and out. But when we do a barium enema, we actually fill the patient backwards or retrograde. And then you would have the cecum down here. Now these things right here, these bright radiopaque objects, those are actually in the spine. Those are rods that are placed in the lumbar spine. That is not part of the actual exam. This is a lateral view of the rectum. You can see this on page 503, figure 13.11, just showing you the relationship of where the rectum actually lies in relation to the sacrum and the coccyx. This is where the enema tip gets inserted, is through the anus and then into the rectum. And then when the radiologist directs, we begin to fill the large intestine with barium. Again, here's a slide referencing the differences we said in the large versus small intestine. The internal diameter is different between them. The large intestine has haustra. These bands are sac-like pouches. These longitudinal muscle bands are the tinea coli. There's 3 longitudinal bands that actually pull this intestine into pouches in the large intestine. And then lastly, we did say that the location of the small versus large intestine is another difference. One that they don't mention would be the amount, because small intestine is typically approximately 15 to 18 feet when the patient is alive, and it can stretch up to 23 feet when there is no muscle tone and the patient is dead, whereas large intestine is typically about 5 feet in length. This air and barium distribution is at the bottom of page 503, and while it is important, we tend to look at that more when we do a double contrast study, because the relative location of the barium, which is the white, and the air, which is the black, is different depending on if the patient is supine or prone. So we will come back to that when we talk about a double contrast barium enema. This is a radiograph of the lateral rectum. You can see the sacrum right here, and then the coccyx down here. So sacrum, coccyx. You can see this is part of the pelvis right here. You can see the head of the femur sitting in the acetabulum. That is the hip joint right there. You can see the enema tip with the retention balloon inflated, and then you have the rectum going into the sigmoid colon, and you can see that the tip is still in the patient. This is one of the last images that we do take on a single contrast BE. Some of the clinical indications for a barium enema, these are your pathologies, and these begin on page 512. Okay. The patient might have colitis, which is a thickening of the wall of the large intestine that can become inflamed, or it could be that they have ulcerative colitis. And remember, on these little charts, this is where the registry likes to ask you questions. So ulcerative colitis tends to have a cobblestone or a stovepipe appearance when it's extreme cases. The diverticulosis and diverticulitis, when a patient has the condition of having multiple diverticulum, they have diverticulosis. If those diverticulum become inflamed, then they would be experiencing diverticulitis. Okay, and if the patient has that, this is little, almost like, there's a picture of it in the next few slides. They're little outpouchings of the intestinal wall. So diverticulum project outward, and sometimes they reference that it can give a saw tooth appearance to the mucosa if the patient has diverticulosis or diverticulitis. Intussusception, I know I skipped neoplasms, but this one down here, intussusception is a telescoping of the intestine onto itself. This telescoping of the intestine, typically it happens in children, infants, under the age of 2. And if that is the case, then sometimes what we'll do is like an air enema to kind of pop that section of the intestine out from the other section. Neoplasms again, these will represent as filling defects. Sometimes they will reference that they have an apple core or a napkin ring lesion. You can see that here. They reference it looks like a napkin ring, the things that would hold like a cloth napkin together, or this as an apple core sign. Okay, so that would be indicative of a neoplasm. They're especially concerning, I would say, in the large intestine, because even though you can have a benign tumor, I just blanked, I'm so sorry. Cancer of the large intestine is fairly common. That's why they do suggest colonoscopies, typically at the age of 50, but if there is family history, they usually will start those as young as 40 years of age. A volvulus, that is where it's a twisting of a portion of the intestine on its own mesentery. So what happens with that, think of like a balloon animal. If they were going to make a balloon animal, they would inflate the balloon and you would just have this long balloon. That's normal. That's how we want the intestine to be. Volvulus is where it twists on itself. So like when they go to make the balloon animal and they twist the section and it kind of cuts off, that's exactly what happens in the intestine. And when it does that, when it twists on its own mesentery, it cuts off the blood supply. And ultimately and very quickly, that can lead to necrosis or death of that tissue, and the patient can become septic and pass. There was a patient that had gone to the emergency room twice in one evening for severe abdomen pain, elderly woman. The first time they told her they didn't really find anything, everything sounded normal. They listened to her with the stethoscope and they sent her home. She was at home with her husband for a few hours and they came back, and she said that the pain was just excruciating. They did do an AP supine abdomen. They didn't see anything on that and they sent the patient home. And the next morning, the husband woke to find his wife deceased in the bed beside her. And then upon autopsy, it was found that she had a volvulus. And when it twisted, literally you could see the intestine had turned green and it was dead in that section. And the patient ultimately died from sepsis. The last one on here, this appendicitis. As I said before, typically when there is a suspected case of a patient having appendicitis, they typically will not do a barium enema. The danger with that would be that they perforate the bowel, which would not be good. And if they do suspect the patient has appendicitis, typically they will send them to ultrasound for imaging, or they can perform a CT scan as well. Either of those modalities would be safer for the patient versus having a barium enema for appendicitis. These are some images of ulcerative colitis. This is the one that tends to look like cobblestone. They talk about cobblestone appearance on there. This is figure 13.3 on page 512. This is diverticulosis. You can see these little outpouchings. I always say they look like little dingleberries off the large intestine. And when the patient has a barium enema, you can see these little pouches fill with barium. So the question reads, what's the difference between diverticulum and a polyp? And the answer would be the direction which they project. So diverticulum project outward from the lumen of the intestine, meaning there's an outpouching. A polyp projects inward towards the lumen. This again, we saw this before. This is the neoplasm, the napkin ring or apple core sign. Cecal volvulus, the twisting of the intestine on itself. This is showing you that the cecum has done that, and you can see, even though this radiograph isn't the best radiograph I would think they could have for this, you can see that all of this is air. This is fecal material here. This is actually figure 13.34. So that is a cecal volvulus, meaning the cecum has twisted upon itself. Okay, a barium enema procedure. This is a little bit more involved study than what we've done so far. I would say this is probably one of the most involved procedures that we do. We spend a lot of time with the patient. I can tell you that patients typically come in and they are miserable. The patient's prep for a barium enema typically varies according to their provider. But the bottom line is they need the entire large intestine cleaned out, empty, free from any fecal material so that imaging can take place. Okay. So what they actually go through varies according to the provider, but it does include bowel cleansing cathartics. Cathartic is a technical term for laxatives. I will tell you that the registry loves to use that term, so make sure you're familiar with that. This says NPO after midnight, but I will tell you a lot of preps, they might be NPO after midnight, but they also haven't had much of anything besides possibly Gatorade, Jello, chicken broth, beef broth, things like that. They haven't had anything with substance usually for at least 48 hours. But they're NPO after midnight, no gum chewing, no smoking for the increased air. And then typically, along with everything they've done, they usually have to do one more Fleet's enema the morning of the exam. So again, when they come, they're not really happy to see us because they've basically spent the last 1 or 2 days in the restroom. They haven't had much to eat, and they're usually not overly pleasant. But once the exam's over and they resume back to their normal diet that they had previously and they're done with it, then they're usually a lot happier on the way out than when they are coming in. The cathartics, when we talk about that, they mention these on page 514. A cathartic is a substance that produces frequent soft or liquid bowel movements. A synonym for a cathartic would be a laxative. Now, there are some contraindications to using the cathartics. That would be if the patient has gross bleeding. Now, gross in that scenario means a lot, like significant rectal bleeding. You would not want them to do the cathartics. Severe diarrhea, if they have a possible obstruction, and or if they have any kind of inflammatory lesions. Anything like if they have colitis or appendicitis or anything like that, you would not want to use any cathartics for that patient. The laxatives or cathartics that are used, typically there's two different classes. The first one they mention is the irritant laxatives, and those are typically like castor oil. They say they're rarely used, but honestly, some GI docs do still like that, and they tend to go with that. The second class of cathartics is the saline laxatives. That would be your mag citrate, mag sulfate. There's all kinds. Some preps use mag citrate along with like a Ducalox, enemas. Their diet is limited. They're pretty involved. It's not just, take a Fleet's enema and you're done. Or usually with the Go Lightly, that's another. Sewer prep is another one. It usually involves drinking, and then it induces bowel movement fairly quickly depending on the patient, but usually by the time they come in, they are literally having just liquid coming from their rectum. So again, not a fun way to spend 24 or 48 hours in the bathroom. The contrast media that is used for a barium enema, typically we are using the barium sulfate as our contrast media, but if the patient did have any of the three contraindications, which are possible obstruction, possible perforation, pre or post surgery 48 hours, or if they've had a sigmoidoscopy or a colonoscopy with biopsies, then we would use the water-soluble iodinated contrast media. Typically, when we have a barium enema study, we have a barium enema kit. Sometimes that kit would look like this bag here on this IV pole. Sometimes it'll come with powdered barium in there, and then we add water through this hole up here, and this is closed off when we start, and then we would mix that, and then you would run the barium down the tip and clamp it off so that it didn't run out. Typically, when you're mixing the barium, water temperature that is used is, people are different on that. There usually is a big debate over what temperature water should be used. Some people say cold water should be used, but A lot of people will report that cold water causes cramping and colonic spasm. Room temperature water is typically what we go with. It tends to keep the patient more comfortable, but you don't want to use hot water because you could scald the mucosal lining of the intestine. So I would argue that you would want to use room temperature as close to body temp as you could get, because then the body is not shocked. If it's too hot, then you can burn the patient. If it's too cold, it definitely can lead to spasm. Spasm is something that's common. You can see that on the monitor, especially when we start to put the barium in. But a lot of times, not only could it be due to the water temp, but patients are typically anxious. They're nervous about the exam, and sometimes that will happen. So if that is the case, they do mention here that a topical anesthetic or glucagon could be given to the patient. So the topical anesthetic, sometimes I've seen them add liquid lidocaine to the barium enema bag. I feel like that would be slightly costly for every patient to do. So if they don't do that, if they don't add the liquid lidocaine to the bag for every patient, then a lot of times what will happen is if the patient starts to have spasm, the radiologist will ask us to prepare glucagon. We talked about that in patient care. Glucagon is a smooth muscle relaxer. It's given intravenously. The only reason that a patient could not have the glucagon is if they were a diabetic patient. These are some of the different enema tips. We looked at these also when we were in patient care. This typically is called an acorn tip. This one is a single retention tip. Notice it has one single port, so this is used for a single contrast barium enema. And this is a double contrast enema tip. So this one would go to the tubing to inflate the patient with air. It's got a bulb syringe attached to it. And this one right here, along with this one, those are what clamp off the air that gets put into the retention balloon. And here you can see this is completely deflated when we first get the tip, and then this one is when the tip is inflated. And that is something, when you are prepping the room, you do want to make sure that you test that balloon. You would want to fill it with one puff of air and just make sure that it's going to stay inflated, because the last thing you want is to put that in the patient and begin the exam and then realize that there was a hole in the retention balloon. As far as room prep, we tend to set up for fluoroscopy just like we would if we were doing an upper GI or an esophagram. The table starts horizontal. When this says cassettes, it's old school. It's basically telling you to have everything ready. Cassettes used to go in the fluoro tower to take the images, but now with some of the digital fluoro systems, that's not the case. It can just take the images as we go. We don't have to switch out the IRs. You'd want to have your contrast media. You probably aren't going to prepare that until after the scout image is cleared, because if you prepare it and then they reference that they're not going to do the exam, there's nothing you can do with this bag once it's made, unless you had a patient right behind that patient that was getting prepped for the same thing. That would be waste. You should always have towels and linens, anything that you might need to clean the room, because occasionally patients do either push the tip out and then you have sometimes a lot of barium leaking out, and then usually when it leaks, it's going to spill over onto the floor. So towels, linen, pillowcase, anything you might need or deem necessary for the procedure. This right here is the footboard that we talk about. You can see it's got little handles right here. That's how it attaches to the table. And then while we were doing fluoro, remember the Bucky would be all the way down to bring out the Bucky slot shield. You can see some of the Bucky slot shield right here. This Bucky is down, but it's not all the way down. This is the footboard. It will tell you on here your patient weight, maximum weight that the footboard can hold. You can see the patient is lying on their side. The enema tip is not really, but for the purpose of this picture, it would be inside the patient. This is a double contrast that they're showing you because that's the bulb syringe that we fill with air. You've got the barium bag on the IV pole, and we'll discuss the fact of that can be no more than 24 inches above the table, which is approximately 60 centimeters. You can see the fluoro tower is pulled out over the patient. You've got the lead drapes here as added protection. All the controls are here for the radiologist. And then you can see the monitor so that we can watch as we're directed to let the barium flow. We'll watch on the monitor along with the radiologist to see the large intestine fill. For enema tip insertion, the patient is on their left side with their right knee bent. That is Sims position, and that is the position that we use to insert the enema tip. So this is how your patient would be lying on the table when they're getting ready for their exam. Now this exam, recognize this is the only exam where the patient has no clothing on whatsoever. No underwear, no pants, no shirt, no bra, nothing. Mainly because of the area we're imaging, but also if the patient did have any clothing on, I usually have them remove shoes and socks as well. If barium gets on any of their clothing, it does not wash out very well at all. So that goes for our clothing as well. That's why, I don't know if you've seen, sometimes they make like moisture resistant uniforms, like where the liquid repellent, they put something in the uniform material that repels liquid. So I feel like if we were doing floral all the time, that would be a really nice uniform to have because it means that the barium wouldn't likely soak into your uniform. It would just kind of roll and bead off. So patients are typically naked. Gown would be on with the opening in the back, and typically we have a sheet over them as well. When the enema tip is going to be inserted, remember you should have already tested that tip to make sure that it's functional. You're going to want to talk to your patient because they usually are very apprehensive on this part. Gloves, I usually tell you to put 2 pairs of gloves on. It's very hard to put gloves on once you've had a pair on and take them off. So if you have 2 pair on to begin with, then it's easier once you tip the patient. You just take off your top pair of gloves and throw those away, and then you're good to go with the other pair already on. You would drain any air from the enema tubing when you mix the barium. Eventually you will pop the tubing so that the barium flows down the tubing. You just have to make sure to stop it at the end, otherwise it will come pouring out the tip long before you want it to. The tip, typically we will put lubrication on the enema tip. There is Surgilube, which is almost like a Vaseline jelly that goes on there. When I used to do them, I did have a lidocaine gel that I would put on there as well, because a lot of your patients are going to have hemorrhoids. If they had them before, they're definitely going to be inflamed from their prep for this exam. So sometimes putting that numbing lubricant on the tip, if you have access to it, and then putting those on putting that numbing lubricant like lidocaine on their hemorrhoids before you insert the enema tip is just kind. It feels better for the patient, and you can do that right with the tip. You can just put the lidocaine gel on the tip and then kind of put that over the hemorrhoids with the enema tip. Even if they don't have hemorrhoids, you do have to lubricate the enema tip before you insert it into the patient. Now, as far as insertion of the enema tip, you are going to hear me repeatedly say the enema tip is inserted up and towards the umbilicus. Okay, up and towards the umbilicus. They reference that the rectum has a double curve. So typically your enema tip is inserted, if you read this, it says it's inserted in a forward direction approximately 1 to 4 inches. This should be aimed towards the umbilicus. After that, it's directed superiorly and anteriorly to follow the normal curvature of the rectum. Total insertion of the tip should not exceed 3 to 4 inches to prevent injury to the wall of the rectum. Okay, that sounds super complicated, okay? But what I'm going to tell you is that this is not thought involved. The hardest part is getting the enema tip past the sphincter, because it's not normal for something to go in the opposite way. So patients really don't like this part. This is where you're kind of talking to them. You're, telling them, okay, we're going to go ahead and insert the enema tip. I just need you to breathe slowly in and out your mouth. Or sometimes I tell them breathe in your nose, out your mouth, and then you slide the tip in, and you do go up and towards the umbilicus, but basically the tubing kind of guides itself. It's not like you're directing it. You're not thinking, okay, I'm going 1 to 4 inches forward, and then I'm going towards the belly button, and then I'm going superior. You're not thinking that at all. You're literally just sliding that in. If you've ever had a child and done a rectal temperature, you know that the thermometer just goes in. If you're a female, then, it would be no different than inserting a tampon. You're not thinking about the direction. You just kind of put it in there, and then it follows the path of the patient's anatomy. The enema tip does the same exact thing. This is not super thought involved, but when they ask you how is the enema tip inserted directionally, you would want to say it's inserted up and towards the umbilicus. And this picture for reference is on page 517, figure 13.4. Now, I will tell you, while we're still on this, let me say, if you start to put the tip in and you meet resistance, meaning it's very difficult, do not force the enema tip, okay? Don't force the enema tip at all. You would just wait and have the radiologist just let them know that you met resistance when you were putting it in and you didn't feel comfortable. And usually what they'll do is fluoro, and then we can insert under fluoro, or we can at least make sure that nothing's going on. Because if you force that enema tip, you definitely could perforate the rectum, and that is not what we want. Once you get that tip in place, we are only allowed 1 puff of air. Okay, we're allowed to place 1 puff and clamp that. If they require a second puff of air, that is not allowed unless the radiologist is in the room and we are directed to do so while they watch under fluoro. So once that enema tip is inserted up and towards the umbilicus, we inflate the balloon with 1 puff of air and clamp it. And then remember that bag is no higher than 24 inches or 60 centimeters above the table. All right. As far as the lower GI imaging that we can do a single contrast enema, a double contrast enema, or we can also do what's called evacuative proptography. But today in this lecture, we're only going to talk about a single contrast barium enema. You always want to review the chart on the patient before you begin any study, really. But with a barium enema, you want to make sure you're looking and making sure there's nothing that indicates the patient couldn't have barium, whether they are pre or post surgery, a possible obstruction, a possible perforation. And then there are two more things that we have to add to our history. One is we have to ask if they've had a colonoscopy recently. And with the word recently, I would say that would probably mean within the last week. If they had a colonoscopy or a sigmoidoscopy in the last week, you need to know if they took biopsies. Because if they took biopsies, it is possible that there could be a perforation in the rectum, and the radiologist would need to make the decision if we use barium or the water-soluble iodinated contrast. That's one additional question. So surgery, what's going on with you? Have you had a colonoscopy recently? And do you have a latex allergy? Okay, most things in the department, most gloves, the balloon on the retention tip, typically they are latex free, but you have to know if your patient has a latex allergy, because the smallest amount of latex powder in the air could send that patient into a reaction, and depending on what that reaction is, it could be anaphylactic. Okay? Same with you. If you have a latex allergy, you would have to make very sure that everything you used was latex free. Like I said, most things are, but you definitely need to double and triple check if your patient has a latex allergy. The height of the enema bag should never be more than 24 inches above the table unless you're directed to do so. If it's not going in, sometimes the radiologist will tell you to raise the bag, and as long as you're directed by he or she, that is perfectly acceptable. Never force the enema tip. We mentioned that when we insert it, never force it. If you're meeting resistance, tell the radiologist and we can do it under fluoro. And then verify that your contrast media is not too hot and not too cold. But ideally, you're the one that mixed it, so it should be tested at the time you are mixing it. All right. Now, as far as our routine, you have paperwork that shows the routine that we do. The highlighted positions on here are our routine in order. Okay, we would always do a scout image before anything begin with the exam, because we need to see what everything looks like before we start. So the scout image would be an AP supine abdomen, whether that is 1 IR lengthwise, 2 IRs placed landscaped one another with overlap, or a T-shot. Whatever protocol is, you would do the AP supine abdomen according to protocol. After that scout image is cleared, we come back in and set up. We would eventually tip the patient, set up the fluoro. The radiologist would come in, we would introduce, and our job during the exam itself, typically what's going to happen is that the radiologist or the fluoroscopist is going to dictate when the barium is on and when the barium is off. So when they are in the room and they tell you to have the barium to start flowing, they're going to say barium on. When they say barium on, we repeat barium on once we release the hemostat or the clamp. Okay? When they say barium off, we repeat barium off and we clamp the tubing. The reason we do that is so that we can audibly respond and let the radiologist or fluoroscopist know that we heard and understood, and that's what we're doing. Okay, it'll be stopped and started multiple times during the exam, and every time they say barium on, we repeat it. If they say barium off, we repeat it, and we do whatever it is. We either open the clamp or close the clamp. So our routine is to do first an AP axial, we call that a butterfly. Then we do an AP. Then we do both obliques, RPO and LPO. Then we do a left lateral rectum. And then On a single contrast study, we always do what's called a post-evac image. Now, our first image, this AP axial, this is going to be kind of confusing, so try to listen and bear with me. The whole point of this particular image is to straighten out the sigmoid colon. With doing that, there are 4 different positions that will achieve straightening out the sigmoid colon. But you only have to perform one of these images, okay? So the 4 there are to choose from, this lists 2. You have an AP axial, that is on page 535, as is the AP axial oblique. So this is the AP axial, this is the AP axial oblique. That's 2 of them that would demonstrate what we need. The other 2 are referenced further in this PowerPoint, but they are on page 536, and they could do a PA axial or a PA axial oblique. So there's 4 positions: PA axial oblique, AP axial oblique. Any of those 4 would straighten out the sigmoid colon. What we are going to practice, and what most facilities do, is this AP axial oblique. AP is referring to how the central ray is passing through, anterior to posterior. Axial implies that there's an angle of more than 10 degrees. So anytime you see the word axial, it implies angle of more than 10 degrees. So for this particular image on 535, you would be at a 40-inch SID. So these are considered our overhead images. Okay. These overhead images are done after the radiologist leaves the room, and they are done in this order. So you're at a 40-inch SID. You are on a 14 by 17 portrait. Your KVP range is 110 to 125 for single contrast, 90 to 100 for double and water-soluble contrast. So make sure you write these techniques down. For a single contrast AP axial, we're going to use 125 at 3.3 mass. For double or water soluble, we're going to use 100 at 3.3 mass. On the AP axial, the patient lies supine. The central ray is angled 30 to 40 degrees cephalic, and the central ray is 2 inches below ACES at midline. 2 inches below ACES at midline with a 30 to 40 degree cephalic angle, and 125 at 3.3 for single contrast. Notice under the anatomy demonstrated, it says you get elongated views of the rectosigmoid region. So here you can see the enema tip right here with the balloon inflated. This is the sigmoid colon, but it's straightened out. Look at the pelvis. You can see the angle on the tube just from the way the ilium are projected. So this is your goal, a straightened sigmoid colon. This is the one that we are going to practice. Some facilities may do the AP axial oblique, the LPO. That is on the same page. They just tell you you would rotate the patient into a 30 to 40 degree LPO. Your central ray is still 30 to 40 cephalic, but now you enter, your CR is 2 inches below ACES, and 2 inches medial to ACES. But we are not doing this one. We are only going to do this. So you're 2 inches below ACES at midline. All right, after this, again, is on 536. This is 2 more views that will show a straightened sigmoid colon. You could do a PA axial or the PA axial oblique, which these are both basically the opposite of what we just did. And anytime something is opposite, because we just angled 30 to 40 cephalic, so when you flip the patient, you would flip the angle. So now we're 30 to 40 caudal if we did this. But out of those 4 that are listed on 535 and 536, we only do one of those views. As far as, I know this says PA axial and PA axial oblique because they're showing you this. You want to elongate the rectosigmoid colon, just like we said on the AP axial. And this is a double contrast study that we're looking at. And yes, they do the same image for a double contrast. Next our protocol is AP barium enema. Okay, so the AP barium enema is on page 527. You're still at a 40-inch SID. You're still on a 14 by 17 portrait, assuming your patient fits that way. Your technique, I know you're going to be shocked, but it's 110 at 2 for single, 90 at 2 for double or water soluble. Patient lies on their back. The central ray is now perpendicular, and it's centered to iliac crest and midline. All of these images are of the abdomen, so all your respiration is exhalation. Taking a breath, blow it all out, hold it out, don't breathe, beep. Notice too that we're using all these IRs as if the patient fits, but if the patient did not fit on one IR portrait, you would be forced to do 2 IRs placed landscape with overlap. And protocol everywhere we go is that the enema tip stays in the patient until you're done with the left lateral rectum, and then you check all your images before that is removed. As far as the anatomy demonstrated on an AP, you want the entire large intestine demonstrated on this image. Ideally, everything is full of barium, but primarily the transverse colon. No rotation. We can see that in the spine, that they're not rotated. And everything looks good on that. After our AP, we are going to do PO obliques. So the book does show AOs, but that is not our protocol. So these are found on page 530 of your book. Still 14 by 17, either portrait if your patient fits, or you would be forced to do 2 landscape if your patient did not fit. Your technique is the same, 110 at 2 for single, 90 at 2 for double or water soluble. And the patient is rolled into a 35 to 45 degree oblique. I realize this slide says 35 to 40, I'm sorry, it should be 35 to 45 degree obliques, which means we'll use the oblique sponge. Central ray is perpendicular and it's at the crest and 1 inch to the upside. So what that means is if you're looking at the patient and her midline might be right here, the middle of her, this crosshair goes to the iliac crest. This one goes from the middle 1 inch towards the side up. So on this LPO, it's going to go 1 inch to the right of midline. And on the RPO, it's going 1 inch to the left of midline. What these do is they show an unobstructed view of the upside flexure. Okay, so on these, on the POs, on an LPO, you're going to demonstrate the side up, so the right hepatic flexure, and on the RPO, we'll demonstrate the left splenic flexure. So when you look at the LPO, so left iliac wing is elongated, right is foreshortened, so they're rolled to the left. Ideally, you should have all of this on here, but the LPO demonstrates the right hepatic flexure, untwisted or unobstructed. And on the RPO, where now the right side is down and the left side is up, now you can demonstrate the left splenic flexure, unobstructed or opened up. Okay, after both obliques, and I would do the RPO first and then the LPO, because that would be the best for patient movement. After that, we do a lateral rectum. It's a left lateral rectum, and that's on page 531. On this particular image, you are going to collimate to 10 by 12 portrait. Okay, everything else has been pretty much wide open, 14 by 17, either portrait or landscape. This you're collimating to 10 by 12 portrait. Your technique on this, notice you're going through more of your patient and you're trying to get the rectum. So this is 110 kVp at 20 mass for single, or 90 kVp at 20 for double or water soluble. For this, you have to make sure your patient is completely lateral, meaning their hips and shoulders are on top of one another and their back is straight. Central ray is perpendicular, and your CR is at ACES and mid-axillary or mid-coronal. Okay, so it doesn't matter, I'm not trying to be funny, it doesn't matter how big their backside is, the rectum is not going to change from being midline even if they have a big backside, because that is not bone structure typically on their backside. So you're at ACES and midline. Okay, ACES and midline, ACES and mid-coronal, horizontal beam. And ideally on this image, the image we saw before in the beginning of this, you are demonstrating the rectosigmoid region, and notice the tip is still in the patient. So this shows the rectosigmoid region full of contrast. And once you finish this image, you would go have all of those checked and make sure everything's good. So your AP axial, your AP, your RPO, your LPO, and your left lateral rectum. If all of those images are good, then what you're going to do is come back in the room. You're going to put the patient on their left side. You would drop the enema bag to the floor, and you would unclamp the bag so that gravity would help draw the barium out of the patient back into the bag. So it'll run into the bag for a few minutes, and at some point it will start to trickle and slow down. At that point, you would want to clamp the bag closed. You would deflate the enema tip balloon, the retention balloon, deflate the balloon, slide the tip out, and throw everything except the thing that blows up the balloon would go in the garbage. You would get the patient up and assist them to the restroom. Typically, the restroom is attached to the fluoroscopy rooms. So you would put the patient in the restroom and tell them to sit, and they can empty anything else that's left in them. They can sit there for a few minutes while you clean up the room. But after a few minutes, you bring them out and you put them back on the table, and then you end up doing what is called a post-evac image. So post-evacuation means after they've gotten rid of the barium. That's what you're basically checking, is that there is a small amount of barium compared to what it looked like when you first started. Okay. This can be done PA or AP. It doesn't matter. Your technique on this is the same as when you started. You're at 110 at 2 for single, 90 at 2 for double or water soluble. And this would be annotated with post-evac. You're on a 14 by 17 open, so you're opened back up on this. Patient is either on their stomach or on their back. Your central ray is perpendicular to iliac crest and midline. Okay. Now, I haven't said it throughout, but realize that this is left marker on the left side of the patient for every image, because we do AP, so left marker down, AP axial, left marker down, AP, left marker down, RPO, left marker on the left side of the patient down, LPO, left marker, left side of the patient down, left lateral rectum, left marker most likely up at the top, just like we do for an upper GI, and then the post-evac left marker down. So you're using left marker for all of these images. The exposure is on expiration, and ideally what you're seeing on this is far less barium in the large intestine than the AP image that you took at the beginning of the exam. So I can't flip back in the PowerPoint, but if you flip back and look at page 527, the amount of barium that you see in that radiograph compared to the amount of barium in this radiograph, it is much less. And that's what you're looking for. Sometimes the radiologist might not like the fact that they didn't get rid of very much, and sometimes I've had them tell me to send the patient back into the restroom and tell them to continue emptying and come out after they've gotten rid of a little bit more. So once you're done with the post-evac image, then, like with any contrast study, we tell the patient, you need to drink 8 to 10 glasses of water in addition to what you normally drink until your stool returns to normal color. So that could be that same day, that could be the next day. We don't tell them to increase their fiber. We don't change anything else about what they do except the water. As far as their diet, unless they were told otherwise, they can resume a normal diet once the exam is done. All right, that has been a long lecture. I want to apologize, but I'm not going to, because I think you have all the information you need. I will tell you, make sure you jot down any questions you might have, any concerns, anything that doesn't make sense, and bring those to class so that I can make sure we answer everything for you. Make sure you write down techniques and positions, follow that little outline cheat sheet that we have as far as the flow of the exam, and I will see you guys soon.